Hello, and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning platform of the American Association for the Study of Liver Diseases. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, and I serve as Associate Editor of CLD. And I'm pleased to welcome Becky DeCamillis to talk to us today about her report that's being published in CLD, Screening for Hepatitis C as part of an opioid stewardship quality improvement initiative, identifying infected patients and analyzing their linkage to care. Becky, welcome. Thank you so much for reporting the results of the Quality Improvement Initiative. Perhaps you can just give us a little bit of an overview of what is Novant Health, and then briefly describe the Quality Improvement Initiative that included screening for hepatitis C for persons with an opioid use disorder.
Sure. Thanks for having me this morning. Novant Health is a healthcare system centered in North Carolina and across the Southeast. We have 16 acute care facilities and over 600 medical group clinics. This quality improvement project was really part of a long-term goal surrounding opioid stewardship and to increase hepatitis C testing in the opioid use disorder population. We implemented an EHR clinical decision support tool, prompting our providers to screen for hepatitis C in these patients over about a 2.5-year period. Our study looked at the number of patients who tested positive and if they were linked to care. At the end, our team reached out to those patients with outstanding care to attempt linkage. We found that about 28% who were tested actually screened positive for hepatitis C. And at the end, only about 23% of those who needed care were linked to care. We looked at mortality as well. There was an overall mortality rate of 8.5%. And we also looked at cure rates of those who were linked to care, and that was about 35%.
I think a number of key lessons learned jumped out at me when I was reviewing your report. Number one, this was a very formal, well-organized approach to routine screening. So really got all the management structure involved in committing to this. And then you put in place a best practice alert, which prompted clinicians to order the test. And that worked very well, and with a high percentage, about 80% of people, that were targeted for screening were screened, and so that's really great. And then you also had put in place what's called reflex testing, whereby a PCR followed a positive result of the antibody test, and those are well accepted practices that really improve testing. So actually, your BPA element was a big success, but really targeted the biggest challenge was on the linkages to care. You want to give us a little bit more of a sense of where that worked well and where it did not work well within your system?
Yeah, I think you summarized it nicely. So in the 2-year interval prior to BPA implementation, screening rates of this population was 8%. Post BPA implementation, it was at 79%, as you say. So we saw great increases in screening this high yield population. Where we were surprised was the poor linkage rates. So a big lesson learned for us is that while we can implement a BPA and increase these screening rates very effectively, that has to be coupled with concurrent provider education on what to do with those results, in addition to having a robust support network of resources to link these patients in real time at the point of encounter.
Yeah, I think there's even more detail in the report, more than we can obviously go over in this short video today. But one other, as an example of that additional information was that clinic that was also providing drug treatment for opioid use disorder, had the highest rates of linkages to care. And, any sense of why that clinic had better success than others?
Sure. Well, the N size was quite small of about 10 or 11. We did see that our one clinic who the physician and his APPs there do have a robust MAT clinic there. And we noted that they had a very high linkage rate of those 10 patients. And that probably speaks to just the relationship between those providers and their patients. Good follow-up of those patients. We found that even patients who were linked to a Hep C specialist, in certain cases, they would go to one visit and fail to follow up. So establishing good patient or provider relationships is paramount in getting these patients linked and treated.
Yeah. No, I think you really provide a number other aspects of the challenges and linkages to care that your report really lays out what needs to be addressed to really improve that linkage after the broad acceptance of testing. How do you go that extra effort to achieve the ultimate aim, which is cure of hepatitis C for these patients? I thank you again for the report. Any other elements of the report you want to touch on before we close?
I don't think so. I think I hit all my high points here. I had scribbled on my pad here. So thank you for the directed questions.
No, it was great. Thank you so much again for the report. Really is critically, this report is critically important at this moment for the U.S. As you point out in your introduction, hepatitis C incidence is rising in the United States. Much of that is related to injection drug use. Most of that is among opioid injectors. We've had a threefold increase in incidence of hepatitis C among young persons, particularly in the southern part of the United States where Novant Health is located. So this quality improvement initiative was critically important, and your report provides a number of lessons learned for us to improve testing linkage to care for this high-risk population. Becky, thank you again for joining us for this installment in the Clinical Liver Disease video series. Thank you again.
Thank you.